Hey team, this is Captain Marchese. Today I'll be recording a lecture on Heent, but it's really like 90% eyes and 10% Hent, because eyes, with our big emergency things, it's life, limb, eyesight, and so eyesight can be very, very scary if we don't identify the big scary things. And so mostly focused on eyes, and then we'll also touch on ears, nose, and throat a little bit. The goals here are to familiarize all of you with HENT related conditions, and then how to properly document those, how to report them to me, and how to make the proper decisions of disposition, where this person needs to go, whether they can be discharged on kind of like a home treatment self-care protocol, or if they need to go to MOD, or if they need to go to the emergency room. This is just basic anatomy of the eye, so that you can describe where an issue is. And then to the right, this is a little more detailed. I wouldn't necessarily expect you to memorize all these things, but this is just if you slice through someone's eye and you're looking at it from the side, this is what it would actually look like. So one big term that I want you all to be familiar with is scleral injection. That way, when you're writing your 5181s in your objective section, you're going to tell me, general impression, whether this person looks very sick, but you're going to tell me if it's specifically an eye concern, whether or not they have scleral injection. This can tell me a lot about what may or may not be going on with your soldier. And so the physical exam for the eyes, there are three major components of the physical exam for the eye. And that is your testing visual acuity. And so that could be as simple as having them cover one eye, hold up a certain number of fingers, and ask them to tell you how many fingers you're holding up, just a couple feet away from their face. If, we're kind of questionable about whether or not their visual acuity is intact, you can also have them look in the actual Snellen chart and get like a, 20/20 number of their visual acuity. Next thing is extraocular movements. If you look to the right here on this picture, that actually shows you what the extraocular movements are. And so it's important that you make a big H and make them go through that full range of motion. The next is Pearl. And so that's pupils equal, round, reactive to light. And some people put the A at the end of that, Perla. That's accommodation. Not a bad idea to check accommodation. Those of you who have worked with me in the clinic, you know that every single eye issue or neuro exam that I do, I'm not always checking accommodation, but that would be like having someone look at the wall behind you and then quickly look at something closer up and making sure that their pupils are reacting to that too. The biggest thing that I always check is pupils are equal, round, reactive, and I'm flashing the light in each eye twice. So if you don't flash the light in each eye twice, you're doing something wrong, because you should be flashing it in the eye that you're looking at, and then you flash it in that same eye again while you look at the other eye. And so you're making sure that they're both reacting equally. And so if everything's normal in a physical exam of the eye, your objective could look something like service members in no acute distress, they're alert and oriented ×4, just because those are the basic things that I always want to know. And then visual acuity intact, EON's intact, Pearl, and negative proptosis. We'll get into proptosis a little bit more later, but proptosis is like big red flag if it looks like one eye is protruding compared to the other eye. That's a bad day. So now we'll get into some this versus that, because there are a lot of things that present very similarly with eyes and need to be treated very differently. And so our first this versus that is a chalazion versus hordeolum. And you can remember this, that hordeolums hurt. And so hordeolums are commonly known as styes. So chalazions, they're a blocked meibomian gland. They're usually non-tender, and your first line treatment for this is just having them put a warm compress on it for 15 minutes a day, or 15 minutes 4 times a day. And so they have to actually do it multiple times a day, or else it's not really going to make a difference. So if they come back and they're like, yeah, I did warm compresses and it's not going away, important question to ask is how many times were you actually putting that warm compress on? Because if you're just doing it once a day, not going to make a big difference. And then hordeolums, these are actually little abscesses. And so these are usually a little bit painful. And first line treatment for this is also warm compresses, may or may not require an antibiotic ointment. Usually we try warm compresses for a little while, and then if that doesn't help, that's when we try the antibiotic ointment. Our next this versus that comparison is a subconjunctival hemorrhage versus hyphema. And so subconjunctival hemorrhages are very, very common. They're completely benign. And if you can see where that bleeding stops, so it doesn't cross into the iris, and that's important. So if it doesn't cross, that's benign. Vision should not be affected, and these just go away on their own. So this is basically just a popped blood vessel right there. It will resolve completely on its own. It might take a couple days, up to a couple weeks. These typically happen, let's say, if somebody deadlifts really, really heavy, or they've been throwing up a lot. Sometimes this can show up. That is not to be confused with a hyphema. So I have only heard of hyphemas occurring in the setting of trauma. I've never really heard of a spontaneous hyphema. But if you see bleeding that's collecting in the iris like that, that is bad news, bad day. That person needs to skip me at MOD and they need to go straight to the emergency room because that's where we're looking at life limb eyesight. So next we're going to look at different types of conjunctivitis. There's a lot of things that go into determining the differences between those. And the biggest one that you need to be able to recognize and know how to treat is bacterial. And so bacterial conjunctivitis is a typical pink eye. Everybody's heard of it. Everybody's seen it at some point. This is going to show up in one eye and they're going to wake up with that crusty, like goopy. They might even say their eye was crusted shut and they had to kind of like pry it open. This needs to be treated with an antibiotic ointment. Okay, so that's super important. That person needs to get some kind of treatment for an antibiotic for that pink eye with an antibiotic. It's not something that will self-resolve. Other types are allergic and viral. And for these, they're going to present very similarly because unlike bacterial, it will show up in both eyes. And allergic tends to show up in both eyes at the same time. Viral, the typical story is it'll show up in one eye and then quickly move to the other eye. And then both will start to bother them. Really, to determine the difference between these two, you're going to use the rest of the clinical story that you're getting. And so allergic, you might have the allergic shiners under their eyes. If you can see in this picture, there's kind of those like dark bags under his eyes. He's also going to say like, yeah, I get seasonal allergies around this time every year. And I also, have been experiencing some other symptoms of allergies since the season started. These can be treated with the Pataday drops, and these are fantastic. They work really, really, really well for allergic conjunctivitis. Like these people are going to love you when you prescribe them Pataday. The viral conjunctivitis, they're going to have, so instead of having that goopy discharge or the purulent, like kind of like green, yellow discharge that's crusty, they're just going to be very, very watery. And they're going to have other symptoms of some kind of a viral infection. And so a lot of you have heard me explain like, you can kind of determine whether or not, and this is not 100% not textbook, but you can kind of determine if something is bacterial versus viral based on how widespread it is. So bacterial infections tend to pick one spot and then wreak havoc at that one spot. Say like strep throat, like that person's main complaint is going to be that their throat hurts. Whereas viral infections, say like COVID, they just hit people everywhere. Some people get nausea, vomiting, diarrhea. Some people have a cough. Some people have a headache. Some people have body aches. And so viral infections tend to cause way more widespread symptoms. And so if somebody has the itchy eyes and the watery discharge, but they're also having any of those other symptoms, that can point you towards viral. And so viral is completely self-limiting. They just have to fight off that virus. And there's some medications we're going to give them to make them feel better in the meantime. But really, it's just a matter of them fighting it off and kind of suffering through it a little bit. So next we're going to talk about corneal abrasions. These are basically when you get a scratch on the cornea. And so typically they're going to have some kind of a story. Maybe they were out doing night land nav, they weren't really wearing their eye pro like they should have, and a branch hit them in the face. And now their eye is super irritated. That's going to really point you in the direction of corneal abrasion. But that's not always the story, not always the case. And so sometimes we have these people who just randomly their eye just got all irritated. Now they can't keep it open. These people will be like visibly uncomfortable. Like you will see that their eye is red. You will see that they don't want to keep their eye open. If you try to test visual acuity, it'll be very difficult for them because they don't want to open their eye. That does happen sometimes. And it just means that something got caught under their eyelid and caused that scratch, and they really didn't even realize that there was something under their eyelid. And so you can see the picture here. We check this by looking under a woods lamp. And so when we use a fluorescein dye, you're actually able to see where that scratch is. And so this person needs to go to MOD because they need to be prescribed a couple drops that is going to make this a lot better. So our next this versus that picture, this one is the biggest red flag that we need to be looking out for. And so there's two different types of cellulitis that somebody can get around their eye, right? And so periorbital cellulitis, also known as preseptal cellulitis. If you look at these two pictures, a lot of people will say, which one do you think looks worse, right? A lot of people are going to say the one on the left. And it's actually not true. And we'll see a little bit on the next slide why that's not true. But periorbital cellulitis collects in kind of the eyelid and around the eye, but it's not so much behind the eye. And so this is going to be painful and irritated. This is non-traumatic. This person woke up and their eye was swollen, their eye was crusted shut. Maybe they had pink eye for a little while and it didn't get treated, and now they woke up with this. This person doesn't need an eye drop at this point. They need to be on an oral antibiotic, so they need to see me at the clinic. That's not to be confused with our picture on the right. And so I have made a whole other slide, and we'll go to the next slide and talk a little bit more about this. So here is a picture of orbital cellulitis. So our periorbital cellulitis was around in like the eyelid and around the eye. This is behind the eye, and you can tell that by the way that the eye actually protrudes a little bit. So it's very important when you're doing a physical exam on any eye-related concern that you have them either look up all the way and you look almost at the angle like you were trying to look up their nose, or you have them touch their chin to their chest and you're looking down so that you can see if one eye is protruding compared to the other. And so both of these pictures are examples of that, and it can be very, very subtle. And that's why it's really important to look at the right angle and make sure you're seeing if one eye is protruding. This basically means that that infection is collecting behind the eye. This is where we're in that life limb eyesight. This person doesn't need to go to MOD LaPointe Clinic. I can't do anything for this person at LaPointe Clinic. They need to go to the ER. If they have positive proptosis, that's how you would document that, is positive proptosis. And if it's painful when you're doing that H test, when you're testing EOMs, those are big red flags. Not to be confused with discomfort when you're testing EOMs, right? So a lot of times with someone with pink eye, I'm testing EOMs and I'm going to ask them if it's painful. And they're going to say, yeah, it's painful. And I need to clarify, is it just kind of like uncomfortable, like it feels like sandpaper, or like it's like sharp pain behind your eye when you move your eye around? And that usually clarifies like, no, it just kind of feels irritated and like sandpaper is there while I'm moving my eye. That's not nearly as scary, but if they have sharp pain while they're moving their eye around behind their eye, that's a bad day. That person needs to go to the emergency room. And here's some other red flags. These are things that I do not want you to send to MOD, right? Like this is bad news. So if somebody has a foreign body in their eye, I'm not fixing that at LaPointe Health Clinic. Please do not send it to me. Down in the bottom left corner, this is what it looks like when somebody has a detached retina. And so these can happen spontaneously or they can be in the setting of trauma. But if someone describes it like there's a curtain coming down over their eye, that's a bad day. That's not good. Do not send that person to the clinic to see me. Another one I want to point out is the top right corner. And so this is an orbital blowout fracture. The story here is going to also point you in the right direction, right? Like this is someone who just got hit with a baseball or something along those lines, and there's every reason to believe that they might have an orbital blowout fracture. That person needs to go to the emergency room if their eye looks like that, and that person needs to go to the ER. Another example, bottom right corner, this is called anisocoria. Some people do have this physiologically, so if you notice this on a soldier, make sure you're asking them, like, do you maybe take any medications that could cause this, or have you ever been told before that your pupils are unequal? Because some people, that's just normal for them. Most people, that if that is normal for them, they know it and they've been told it before, and so they can tell you that. But if someone just had, say, like a major head injury and all of a sudden their pupils are abnormal, that needs to be further looked into. That's not necessarily, that one can be run by me before immediately sent to the emergency room, but at least you're reaching out to a provider about that. A and B, that person is definitely going to the emergency room. they don't need to go to LaPointe Health Clinic. So that covers eye, and we'll touch on ear for a little bit. This is just a diagram that shows you the different parts of the ear. The biggest thing to note is you'll see where it says tympanic membrane. That basically separates your outer ear from your middle ear. And so outer ear infections, say swimmer's ear, if you've heard of swimmer's ear, that can be treated with a drop, right? But if I give an antibiotic drop to a person who has a middle ear infection, so it's behind that TM, that tympanic membrane, a drop isn't going to get there because the tympanic membrane is going to stop it. So that's somebody who needs to be on an oral medication. And so this is basically what the TM should look like if you look inside of somebody's ear. You shouldn't see any holes in it. It shouldn't be very red and bulging. You should be able to see a cone of light. There shouldn't be like bubbles collecting behind it. This is your normal that you should be able to compare it to. So here's the look of a couple different infections you can get in your ear. So otitis externa, like we just talked about in the diagram. This is swimmer's ear. You'll see kind of like yellow, crusty, cottage cheese looking stuff. This needs to be treated with antibiotic drops. So if we have antibiotic drops at the aid station, that's an option, but really they should be sent to LaPointe if not, because we need to treat this so that it doesn't get worse. To the right, you have otitis media. So this is a typical ear infection that everyone hears about and talks about. What most people think of when they think of an ear infection is this. And so they're going to have pain and pressure in their ear. And when you look in their ear, you'll be able to see the TM, and it might look red and bulging like this one. It might have bubbles behind it. Sometimes there's a little bit of bleeding. It all kind of depends on how severe it is at that point. But this needs to be treated with an oral antibiotic. So this person needs to go to MOD and be put on a medication. Now, the biggest red flag for an ear infection is something called mastoiditis. We don't see this very commonly in our healthy soldiers because really this is seen in kids a lot because kids can't really explain to you what hurts. And so they'll go with an undiagnosed ear infection for a while, and then that turns into mastoiditis. And so if you press right behind your ear, you'll feel a bone that kind of sticks out. That's where that infection gets into. And they need a head CT to diagnose this, and then they need to be treated with IV antibiotics. It is something to check anytime you have someone with an ear infection, just like pressing behind their ear, looking behind their ear to make sure that there's not a red spot there, because there are some soldiers that will ignore an ear infection for too long, and then it could end up as something like this. I wouldn't be totally shocked, but it's not something we see very often. And so just pressing behind their ear and looking back there to make sure that there's not a bump or like severe redness behind their ear is an easy way to rule this out. So then we have tympanic membrane perforations. So this is usually traumatic. It can be caused by very loud noises. It can be caused by blasts. The best treatment is to prevent it. So like wearing ear pro and not using Q-tips. It's hard to get through to some people that they really shouldn't be using Q-tips. They should be instead like flushing out their ears or using the drops like the Debrox instead of using Q-tips because Q-tips can just kind of push stuff further in and they can cause these tympanic membrane perforations. And so these are actually, this sounds kind of scary, but they're really self-resolving. They usually resolve within like 2 to 3 weeks. We see this pretty often. Kids get this all the time when they get an ear infection and then it ruptures, and then it just kind of resolves on its own. So now we'll touch on a couple nose-related things. If you look here on the left, this is a nasal polyp. So you can see where it kind of like bulges out there. Easy to start treating this. We just give them allergy medications and have them use Flonase for a little while. If that doesn't get rid of it after a couple weeks, then we look at maybe like sending them to ENT and they could actually get that polyp removed. And then on the right, you can see a deviated septum. So these can be very, very subtle or very obvious. And you can see in those two different pictures, one example of each where one is very subtle and the other is very, very obvious. If these are a concern, like people will explain that they have really hard trouble like breathing out of one side of their nose. It affects their running. You can test it by having them block one side of their nose and take a deep breath in and then have them do the same thing on the other side. And you'll be able to hear how well air moves through one side and how well it doesn't move through the other side. Next, we'll touch on nosebleeds. You're going to treat acute nosebleeds very different than you're going to treat a chronic issue. If someone has an acute nosebleed, you're going to tilt their head forward, have them blow their nose gently. 2 sprays of Afrin can do the job. Really, having them just pinch it for a little while first is not a bad idea, but if then it won't stop, then you can always use some Afrin. Afrin is not a long-term solution for nosebleeds. That's something that's very, very important. This is to fix one nosebleed that is occurring right now, but we're not going to give this person Afrin and tell them to use it all the time if they're having consistent nosebleeds. Okay, so our chronic nosebleeds, we're going to have this person apply Vaseline using a Q-tip, just kind of like spreading it around in their nasal cavities twice a day. We're going to try daily antihistamines. So if you listen to the medication lectures, that's like our Zyrtec or our Claritin, maybe Allegra. And we're going to stop using Flonase on a regular basis. So using Flonase all the time can actually increase your chance of having chronic nosebleeds. If we do all those things and all those things fail, that's when we look at sending them to an ENT specialist because they might need to have one of those vessels cauterized. And next we'll talk about throat. Basically, the biggest thing you're looking at in the throat is tonsils. The most important thing to know about diagnosing a throat issue is we need to figure out whether or not it's strep, right? And so we'll talk on this on the next page a little bit about Centaur criteria. Here you can just see grading of tonsils, and so if you can't see their tonsils at all, they would be a 0. And covering less than 25% is grade 1, and then 25 to 50 is grade 2, 50 to 75 is grade 3, and then if somebody's tonsils are basically taking up their entire throat, it's more than 75%, then we're calling that tonsil grade 4. And so here's Centaur criteria. This is how we decide whether or not somebody needs to be sent up for a rapid strep test. And so you can see here on the left is a really good example of exudate. Those white patches, those are exudates. And so our Centaur criteria, it is actually an acronym. So it stands for cough absent. So someone who has strep shouldn't be complaining of a cough. Exudate or swollen tonsils. Nodes, so you're going to press on their cervical lymph nodes, the anterior cervical lymph nodes specifically, and see if they're tender or see if they're swollen, if you can actually feel their lymph nodes. If they have a temperature, so a temperature is over 100.4, but you do have to take into account if they maybe have taken a medication that would be hiding their temperature. And then old or young, so most of our service members are between the ages of 15 and 44, so we don't often see a +1 on this, or a negative. We don't often see a -1. We might see a 0 or a 1. And then 2 out of 5 of those being positive does warrant rapid strep testing. So one other thing to note, if somebody has exudate and they have tonsils that absolutely look like strep, and then they're somehow if they're negative on the rest of it, something else to think about is mono. So mono is a very interesting illness. I would highly recommend that you take some time to look it up and read about it. They will have exudates on their tonsils typically, and they may or may not have swollen lymph nodes. But if this is someone who just complains of extreme fatigue and their stomach doesn't feel great and they have a fever, they're someone we need to think about mono. So they'll typically also be positive for at least 2 of these things, because they'll typically be positive for the temperature, for the may or may not be swollen nodes, and then they'll have exudate. So if we have somebody who has some of these symptoms, but they're testing negative for strep, that's the next thing that we need to think about, is maybe they have mono.